Greetings, everyone, and thank you for joining us in this live online series put together by the Patcher Foundation, the Assembly of Pentworth, and Immigrant Community Services to discuss male breast cancer. My name is Josephine Garnham, and I'll be your host for today's segment. Our virtual program is being broadcasted live today, thanks to the great partnership with Afrique Today Online TV that streams live on Facebook, YouTube, and its website, afriquetoday.com. We welcome our viewers from all over the world. Today, the Patcher Foundation and partners' hope is to create a space to raise awareness and inform the public on the topic of breast cancer, specifically male breast cancer. When most people hear the word breast cancer, chances are they think of a woman. But as we know, men can develop this form of cancer too, even though it's relatively rare. Society seems unaware that men can develop breast cancer, which contributes in part to late diagnosis in men. Our esteemed guests are subject matter experts who would welcome and who will discuss the importance of raising awareness on the possible occurrence of breast cancer in men and the associated risk factors. So I'll briefly introduce our panelists and then we will get right on to our discussion. Dr. Emeka Onyewu, Plastic and Reconstruction Surgeon, Premier Primary Care Center, Jamachi Plastic Surgery, and co-founder Sustainable International Medical Mission. Dr. Onyewu graduated from Boston University with a degree in biology. He then attended Boston University School of Medicine as a Commonwealth Scholar. He completed a general surgery residency at the Howard University Hospital, earning honors as the recipient of the Chairman's Award. He was the best intern and the best chief resident during this training, and I'm very familiar with his work personally, so it's quite an honor and joy to welcome him to this conversation. Dr. Onyewu has a special interest in body sculpturing using state-of-the-art techniques, including laser liposuction and autologous fat transfer. I hope I'm pronouncing these well. He also has extensive experience in breast surgery, including augmentation, reduction, lifts, and reconstruction after mastectomy for cancer. Dr. Onyewu serves on the board of directors of the African Women's Cancer Awareness Association, AWCAA. Reverend Dr. Tammy Denisi, am I saying it properly? Denise, thank you. Co-founder and president of Carrie's Touch. Reverend Tammy is co-founder and of a 501c3 nonprofit breast cancer organization established to enrich the lives of African American women diagnosed with the disease. She's a 15-year breast cancer survivor and has spent the past 13 years coaching cancer patients and their families through the trauma of a cancer diagnosis, treatment, and re-entry after a journey through cancer. She is a recognized expert in the field of breast cancer and Black women, and is the co-principal investigator for Project SOAR, Speaking Our African American Realities, in partnership with the University of California, Los Angeles, UCLA. Welcome, Dr. Tammy. Dr. Ronald Thorpe is a professor in the Department of Health, Behavior, and Society, founding director of the Program of Men's Health Research in the Hopkins Center for Health Disparity Solutions, deputy director of HCHDS and co-director of the Johns Hopkins Alzheimer's Disease Resource Center for Minority Aging Research. He holds joint appointments in the Division of Geriatric Medicine and Gerontology in the Johns Hopkins School of Medicine and the Department of Neurology at the Johns Hopkins School of Medicine. Dr. Thorpe is a social epidemiologist and gerontologist who has published over 210 peer-reviewed articles that has significantly contributed to the understanding of how race, SES, and segregation influence health and the well-being of African Americans. We are so honored to have you all today. Thank you so much for coming. So I believe we're going to have a call to action. And Dr. Thorpe, you're going to be giving us the call to action.
Yes, thank you so much for the opportunity to speak with you today. What I want to do is I want to start out with a brief call to action and talk. I know the topic is around breast cancer, but I want to take a step back and give a um, broader pitch for men and Black men, and to think more deeply and carefully about how they approach their health. So I want to start by saying that it's no big secret that, and it's pretty well known that Black men typically have the shortest life expectancy um, with regard to any other race and gender group in the U.S. And in addition to that, we know Black men also have experienced greater sickness. They have earlier onset of disease. They have, and when they end up going to the doctor, they end up having this more progressed illness, and many times earlier mortality than white men and other men of other racial ethnic groups. So the 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 big question here is that we know little about why this is the case, and we don't have a lot of research and best practices about how to approach and better and improve the health and well-being of Black men. So I want to just take a few minutes to talk about a couple things and a call to action for the Black men with regard to the situation, the dire situation we're in, that we have to turn this around. And why do we need to understand these factors that lead to poor health? Is because we want to be able to develop the new policies that meets the needs for our population, and want to be able to ensure that we're getting the best quality and appropriate types of care. And also we want to be able to improve our efforts in primary and secondary prevention. So the one big thing is, so why do we live sicker and die sooner? Why do we as Black men do that? So there's some common behavioral explanations. So we know that Black men tend to take more behavioral risk, work in more hazardous occupations. We're less likely to get preventive screenings, and I'll come back to that one in a moment. And we wait longer to seek medical attention. And some people may argue that this may be about biology, but if it's males aren't fully hardwired to take more behavioral risk or deny symptomology or delay care seeking. So what is it if it's not that? And we also know that um, the inequalities that may be attributed to biology of male, we would see similar patterns across all groups of men, but that's just not the case. We know Black men die earlier and live sicker. So what is the call to action? What can we do? So some of the things I think that we can do, and these are call to actions that we need to think about and be, and I challenge you to do these things. So the first thing is, the first one is, we need to know our family history. It's very important to know your family history. And African Americans, particularly as a culture, we tend not to talk about our family history. We don't want to know what grandmama had or what granddad had and how that may impact us. But that's very, very important for us to have this information and collect this information. So if you're not collecting that information, this is the type of information I think that needs to be collected. Another big thing that I think we have to modify, and it's not an overnight thing, is we have to modify our diet and um, think about our diet and how we approach our diet. And we need to we have to make some modifications. I'm from the state of Georgia, so it's the South. And for me, growing up in the South, our diet was high in fried foods and things of that nature. And as I've grown a little bit older and wiser, I realized that I need to modify some of those things and eat, maybe increase my fruit and vegetable consumption, and cut back on the amount of times I do eat those fried foods, because it's known that fruit and vegetable consumption does improve the health and well-being of Black men. And the other thing is that we have to go to the doctor, and we have to go get annual visits. I charge every person, men and women, but particularly my brothers, if you're not going to the doctor at least annually, you need to make an attempt to go annually, because this is the oftentimes when we get screenings and we get early detection of certain diseases such as cancer. And because it's all well known that we have this progressed illness, and we oftentimes diagnosed at later stages. And I just wonder, if we would have had annual screenings earlier, could we have been either diagnosed earlier and had a better chance of uh, better prognosis. I wonder if that's the case, but I would encourage people to go to the doctor and build a relationship with your healthcare providers and understand that building this relationship, it should be a bi-directional relationship. It should be shared decision making and a conversation. It shouldn't be the doctor talking just one way to you. And it should be, if you have questions, you should make sure you get your questions answered. And then we need to also, the healthcare system needs to make sure that the medical visits and the encounters and things that happen in encounters are warm and welcome and inviting to men. You want to make sure that the environment can be well received. And the other thing that I think that it needs to be a call to action, men, if you go to the doctor and the doctor give you a prescription, they tell you to take it, please take it as prescribed to the extent possible, because adherence to treatment regimens are very important to managing diseases. And we know that oftentimes as African Americans, we tend to have just at least more than one chronic condition. And we want to make sure to the extent possible we adhere to these treatment regimens. And then the final thing I'll note on a call to action that I think is very important and it's very vital for where we are in the world today, what's going on with the coronavirus, is that it's important that we participate in research. Because if we don't participate in research, man, then currently there's small numbers of men in clinical research. And so then understanding how those results really apply to us becomes a problem. It becomes difficult. And it could also result in inappropriate treatment guidelines, policy, and health promote strategies for us. So I encourage you to participate in research, to know your family history, and to get an annual. It's very important to establish a healthcare provider and start having an annual physical exam. I've always say this. I believe that men in general, but this particularly for Black men, we believe in health repair and not health maintenance. That is that most of the time when our first point of entry is through the emergency department, and the call to action is not for that to happen anymore, and for us to establish relationships and do some of the modifiable things that I've mentioned today. And I think if we do that, we can be in a great direction to think about managing and handling our healthcare so that we can remain productive citizens of society and leaders for our churches and for our families. Thank you.
Thank you so much. That is really great. Reverend Dr. Tammy, please talk to us about Carrie's Touch. How did it get started?
Well, Carrie's Touch was founded by my late sister and myself after I was diagnosed with breast cancer. And being a young Black woman with breast cancer, all of the statistics showed me that I wasn't going to live beyond my 5-year mark. And, a lot of people, when they're diagnosed with cancer, they ask the question, am I going to die? But I didn't ask that question. I asked my doctor to give me my treatment instead, show me how I could live. And I just became my own advocate for my own health care. And because I was young and I had children and I wanted to live, I wanted to see my children and my grandchildren and, their children as possible. So that's really where we found it because I couldn't find resources that to me as a Black woman. Um, I went to support groups and just the conversation did not connect with on a cultural level. So instead of complaining about it, my late sister and I founded the organization specifically for Black women. But as we'll hear a little bit later, we've had the privilege to serve a few Black men diagnosed with breast cancer as well.
Thank you so much. Can you tell us what does Carrie's Touch mean to your male survivors who reach out to you?
Initially when they reach out to me, they're a little bit, actually, they don't reach out to me. I find out about them and I go to them. Um, and they're a little apprehensive because, they're men. They're diagnosed with a woman's disease and they're trying to navigate their manhood and this disease and, everything that Dr. Thorpe just mentioned about the disparities and the barriers that we have in our communities. So my approach is to reach out to them person to person, first of all, and breast cancer patient to breast cancer. Remove gender. because if I bring in gender, I'm not a man. I can't speak to what he's going through as a man, but I can speak to him as a breast cancer patient. And so our guest that we'll talk to in a little bit, he'll tell you my first conversation was, well, his first question to me was, what are you going to do for me? And I said, well, I can't do anything for you as a man, but you had a mammogram. I had a mammogram. You had a mastectomy. I had a mastectomy. You had chemotherapy, radiation, and the whole gamut. And I said, let's meet there and let's try to build a relationship from there. And then when your maleness comes into play and my, femininity comes into play, we'll deal with it from there. And he comes in. He's actually the only one that has actually stepped into our support groups. And he, the ladies will fight for him and he will fight for them. The other two men that, I've had the privilege to work with, they don't come to the support group. They're not open, with sharing their stories. But they do come and we connect breast cancer survivor to breast cancer survivor.
That is amazing. Thank you so much for sharing that. Tell us, how has the role of faith and the church in your counseling worked?
Yeah, so the role of faith, I would have to go broader than just serving our males, because in reality, even though the males that come to us or we serve, they have spirituality, they are very spiritual, but that's not what they want from me. And it has nothing to do with, me being a female. That's just, our issue is we're staying at cancer. But with cancer overall, faith plays a huge part in going through the treatment process as well as recovery. I know personally on my journey, if it wasn't for my faith, if it wasn't for my understanding and belief that God would heal my body, restore my body, and then still allow me to have purpose, I had no hope, because science was telling me I was going to die. Commercials was telling me I was going to die. Everything I read was telling me I was going to die. Even my own oncologist said, we're not sure that you will live to see the 5-year mark. And here I am 16 years later, and I get to have this conversation with you because of my faith. And for women who are angry at God, I let them be angry at God. I give them space to have their full brevity of emotions. God is not afraid of our emotions, our feelings, our temper tantrums, or none of those elements. God just wants us to know that God has not abandoned us, God has not forgotten us, and God will be there with us. One amazing opportunity I had is Carrie's Touch built a program, a peer and nurse navigator program in Ghana. We were going through all of the patients' rooms, and there's all these researchers and scientists and doctors, and there's full of people in this woman's exam room. She's, exposed because we wanted to see what breast cancer looked like in Africa. God told me, stand back, let all of the medical professionals go through. When the room is empty, go back in, put your hand on each woman and tell them that God had not forgotten them. I didn't speak their language. Their English was, not very strong either, but they understood the touch and the spirit of God, period. And then I would say to them, I'm a breast cancer, I worked it out, I'm a breast cancer survivor. And the light in their eyes that gave them hope and belief that God could heal them too.
Thank you so much. So that, of course, takes me to the next question. When you talk about people's anger and emotions, what are some of the coping strategies people use, and how can they minimize mental stress, physical stress as they go through this journey?
One of the people go through their angry emotions because they believe that they've done everything right in life, and that a cancer diagnosis is actually a punishment from God. And I tend to tell them that's the furthest thing from the truth. God does not punish us like that. God will discipline us and reprimand us, but their cancer diagnosis is detached from God. With their coping strategies, I encourage them to focus on life instead of on death. And if they focus on life, there's hope. I mean, hope is at the foundation of a survivor's journey, whether or not it's going to be a stressful one or one where she or he feels like they can actually survive this disease. Um, our coping strategies are making sure that they connect, teaching them about healthy patient physician relationships, teaching them how to go into their doctor's office, understanding they have a short period of time. What are your top three questions that you want answered? Then, what is your top question that you want answered when you go to your doctor's office? So, empowering them to go into their doctor's office so they can join together and make informed decisions about what is going to be best for that patient physically and mentally.
Mm.
Work with women and men who are alive, but they are dead because they didn't make a decision with their doctor. The doctor made the decision for them, and then they regret it. So we teach
Mm.
and empower women to go in and make informed decisions about health care. Also, I think Dr. Thorpe mentioned this, that we are some private and prideful people, and we are afraid to ask for help. And teaching them that that is not God's plan for us. It was never God's plan for us to live solo. If it was, God would have never asked Adam and Eve to procreate and populate the earth, right? So God intended for families and communities to work in tandem so that we could all survive. And it's a circle, it's a circle. One day it's you, the next day it's your neighbor, the next day it's your cousin, and we all chip in and help one another. Then we have access to more resources.
Mhm.
When I was diagnosed, my biggest question was, how am I going to take care of my kids after this diagnosis? And one of my friends said, well, we're going to have a celebration of life shower. So we had a shower that brought in resources, financial resources. We didn't want gifts, we didn't want cards, we didn't want flowers, we wanted money. And we asked for it. And we received enough financial resources, married with my disability income, to be able to provide for my family for an entire year. But it never would have happened if we didn't ask. So,
Mhm.
teaching patients that you're not on this journey alone. There is a lot of help and resources. You just have to ask and tell people what you need.
Thank you so much. So having a community around you makes a huge difference for one's mental health and emotional support. So as you speak, I will, Dr. Thorpe, I'll go back to you and please tell us some of the myths, stereotypes, stigmas surrounding men with breast cancer, and how can we as a community help dispel them?
So the first and the largest myth is that you can't get it. That you can't. That's the first. And if I don't say anything else, and you don't hear anything else today about this, it's the first one is that men can't get it. It's just rare they can get it, and once you get it, I think that you should find your support system. I think it's important to find your support system. Now, it's going to be it's rare to find other men that have it, but I'm pretty sure there's some growing support system. And I like what Reverend Denise, is it Denise? I don't want to mispronounce
Yes,
your name.
that's
Okay,
correct.
I don't. Yeah, so I like what she was sharing, that just get in a support system. And men, I'm just gonna say it. We happen to be stubborn. We happen to be stubborn, and we don't believe the oven is hot, although we see the flame until we put our hand on it and we burn. So we're gonna have to. I think we have to be able to think about And we don't want to show that we're weak, because that's a sign. I mean, we don't want to be able to ask for help. That's a sign of weakness. We have to stop all that. We have to take control of our situation, our health, because oftentimes, men prioritize their health differently from women. And we'll, if it's left up to us to buy a loaf of bread for the house or go get our blood pressure medicine, we're going to buy that loaf of bread for the house. And then we'll figure it out later on for ourselves. But we need to be able to start thinking about how we can take care of ourselves, and say, if we don't take care of ourselves, we won't be able to walk our daughters down the aisle. We won't be able to go have that 25th, 30th wedding anniversary. We need to start thinking in terms of how can we think about the future, and be able to, the other thing is to be able to go to the doctor. And I know Reverend Denise said this, but I want to reemphasize this. When you go to the doctor, prepare by going to the doctor. And what I mean by that is that encounter no more than 15 minutes probably. I mean, and then it's really fast and rapid. You need to have your questions ready, and you need to have them prioritized, and you probably need to practice with somebody those questions, so that, because it can be a very vulnerable, for Black men, it can be a very vulnerable experience. I'm now having to humble myself. I've always been strong and been leading my family. Now I'm in a very vulnerable position, having to go listen to someone about and put my life situation in their hands. That's not historically and culturally, that's not what we're used to doing as Black men. And so we have to understand that we're doing this to continue to be better citizens for societies, churches, and families. So I just want to stick with the first one. It can happen. Male breast cancer can happen. And what you need to do, you need to treat it as if you were treating any other condition. It needs to be prioritized, and you need to link up with the resources and support system in place. So, because remember what I said earlier, oftentimes Black men end up in the ER, and they believe we don't do a lot of health maintenance and going to the doctor and get checkups. And I think that's something that we need to do more of.
Thank you so much. Dr. Onyewu, and am I pronouncing your name right?
Perfect.
Thank you. Who is a candidate for breast cancer among men, and what do or should men look for in examining themselves, and what are the symptoms they should be looking for?
All right, so first and foremost, I'm going to piggyback off to Dr. Thorpe. Everyone is a candidate. If you're male, you're a candidate, period. Because it's not very common, and I don't even like to say rare. People say rare. Rare is like something you see 1 in a million. It's actually more common than that. I would say it's uncommon, but it's not really rare. If you're a man, you can get breast cancer. How do you prepare? Well, awareness is the first thing. Like, how does it present? What do you know? What is something that you should worry about? When people feel a lump in their chest, and then they're like, okay, there's a lump, I hope it'll go away. And then a week later, it's still there. A month later, it's still there. A year later, you should get it looked at. You should get it evaluated by your physician, because the one thing I want everybody to leave here with is breast cancer caught early is very, very different from breast cancer caught late. It's a huge difference. You're talking about 96 to 100% survival 5 years versus 22% for cancer that spread. So the earlier you catch it, the better, and it can really be the difference between life and death. So you feel a lump, it's okay to watch it for a week or two. Sometimes you have a cyst that will go away, but if something doesn't go away and it persists and it's getting larger, or even if it's just staying the same, you need to take it to the experts to get them to evaluate it. Whether you don't think, oh, I'm a guy, I can't get cancer, that's not true. And the other thing that people think is that it has to be painful or bleeding or something extreme. No, most breast cancers are painless lumps. They're just a lump, you feel a little bump, that's it. No pain, no bleeding, nothing. So any lump that's in your chest, breast tissue that wasn't there before should be evaluated, because you shouldn't have lumps in your breast or chest.
Thank you so much. That is so important for us to hear. Dr. Thorpe, back to you. Help us better understand the different stages and what are their respective risk factors.
So with regard to risk factors in male breast cancer, I think there the there's obesity is a major risk factor, as it may relates and it cuts across a lot of other chronic conditions. Obesity, family history, and I mentioned family history earlier. You know, for some reason I don't know why we just don't like to talk about our health with our family, and so and I've yet to figure that out. I hope I figure that out here soon. But we don't like to talk about it, and we have to talk about it. No, obesity, you know, family, and also diet. You know, the things that we do eat, and I mentioned these things as well earlier. And it, you know, I think it's extremely important. And I know we're rooted in a background where on Fridays we want fried fish, we want the collard greens with the pork ham hocks in them on Sunday after church. We want the macaroni and cheese with 18 different types of cheeses in it, and the breadcrumbs on top. We want the whole. You can tell them from the South. We want the whole layout, right? But we need to think about backing away from that, and we don't try to do it all at once. You know, do it in moderation and back away, and then you could do it every now and then. You know, if you wanted a piece of fried fish, you could get a piece of. I think you get a piece of fried fish every now and then, but I wouldn't say you want to particularly eat it every day. And managing your weight and managing other chronic, because oftentimes if you're overweight or you're obese, you have other chronic conditions as well that may put you further at risk for certain types of for cancers. And physical inactivity. So there's another risk factor. One of the things I tell people, you don't have to be a marathoner or you don't have to be able to swim. You can get out and walk, you know, and walk and just take your time, start out slow, and then you can build up your mileage over time. But walking has just, it is shown that walking have just as good benefits as running as it relates to weight loss and managing chronic conditions. So we want to think about those types of things when we're doing, when we're thinking about the risk factors for for breast cancer, for male breast cancer. And then also, you know, as it relates to the different stages, I think the risk factors cut across the stages. But I think when you're talking about in the later stages, when you're having treatment and you're actually going to get treated, adherence to the treatment. If they tell you to go once a week, don't be talking about I'm gonna go this week and then I'm gonna go the week after next. It's very important. It's very important for you to adhere to the treatment regimen. But also, I forget who said it, but also I think it's important to have that shared decision making, because in that shared decision making process, there's an understanding of what you're doing and why you're doing. Whereas if it's not, they're just telling you need to do it. And if you don't, oftentimes we as Black people, we need to understand why we do things, right? Because if we don't, we just feel that you're telling us to do something and then it might not get prioritized. So I think those are some very key things that I think people, some modifiable things that I think people could take into account.
Thank you so much. Dr. Onyeo, where is breast cancer surgery needed? What kind of therapy treatment options are prescribed for men?
Okay, so there are two standard treatments for breast cancer. You know, obviously you have to take the cancer out, but whether you take just the piece out or whether you take the entire breast out are both options. If you take just the cancer out and leave the remaining breast behind, you have to radiate that remaining breast to lower the risk of recurrence in that breast or of missing some microscopic foci in the breast. So taking out a piece, which is called the lumpectomy, with a radiation has the exact same survival as taking off the entire breast. And I'll say breast, even though I mean breast or chest interchangeably between men and women. So surgically, you can take off the entire breast, and that's of course where people like me come into play, because then we try to rebuild a breast for the person or a chest wall. Or you can just take out the piece alone and radiate the remaining breast, in which case you don't really need reconstruction unless taking out that little piece causes a huge deformity, and then we'll go and fix that. Those are the two main ways to treat it surgically.
Thank you so much. I think what we want to do, because Dr. Tammy, I know you might be leaving us soon. And so what I would really love for you to do for us is to have our special guest if you could introduce our special guest, Hulon, and we can just briefly, given what Dr. Onyewu and Dr. Thorpe and you have said, I think having that context, having someone talk who has been through that journey, talk to our guest just very briefly, would be very helpful, and then we'll continue the segment on. So, Reverend Tammy, over to you.
Okay, and I no longer have a time restriction. It's worked out.
Wonderful.
It's my honor and my privilege to share someone that has become a friend and someone very special and dear to my heart in his survivorship. 11-year breast cancer, male breast cancer survivor, Hulon Thompson. We welcome you and we are eager to hear your story.
Oh, hello, everyone. Hello, everyone. Thank you, Reverend Tammy. And thank you, Afrique Today TV, for having me on. It's an honor.
Thank you so much for taking the time, Hulon. It's an honor meeting you. Can you please tell us, take us through your discoveries of the lump? What crossed your mind? Who was the first person you reached out to? When did you decide to reach out to a doctor? Tell us a little bit about your story.
Well, there's so much to tell. I don't even really know where to start, but I'll start here. With I believe Dr. Thorpe said how you sometimes can lapse when you first discover it, and maybe a week or two can go by, or a month or something like that. So I actually waited a year, and I didn't want to do that. I didn't understand what I was dealing with, so it took about a year. And the reason that really made me go to the doctor is I was horse playing or what you call like slap boxing, play fighting with my little cousin, and he hit me in the chest, and it was a pain indescribable. Never felt anything like that. And I said, this lump that's been here that I've been trying to ignore and forget about and hope to go away, it hurts right now from that hit. I've never felt anything like that. So that was my call to action. Unfortunately, my healthcare situation wasn't the best, so I had to go through Department of Health and Human Services, like Medicare, and after doing that, I was able to be able to see a doctor and given a long needle biopsy. So there's a lot I can go into. Like I said, I kind of don't even know where to start, but everyone who's speaking today is on point, and they're saying some amazing things that need to be heard. I'm just honored that this is even happening, because with the coronavirus happening right now, I just assumed issues like this would get pushed way to the back burner and no one would even care anymore. So I'm just honored to really be here. I was at the age of 39 when I got the diagnosis after sleeping on it for about a year. So 39 is considered an early onset, and it was someone who worked at the hospital, was a coordinator, that got me in touch with Carrie's Touch, and then that's when everything started to move. But before that, I was lost. I was lost.
Thank you so much for sharing that. And what did you learn from your experience that you can pass on to other men who are watching this program today?
Well, I learned a great many things. At the beginning of the situation of the diagnosis, I considered myself to be a Rastafarian. So I had dreadlocks, and I was done with the mainstream system. And I just wanted to gather enough money and try to move away to Africa or Jamaica or just away. And all that went out the window once I got the diagnosis, and I realized I had to get serious about me, myself, as a Black American man in America. And once I heard the word, cancer, I knew chemo's coming with that. The dreadlocks are gone. And to look around for a Rastafarian hospital there is no Rasta hospital. So I had to get real. I had to get serious. The hospital is in the is in the grocery store, where the vegetables and fruit are. That's what I had to partake in. these dietary changes, it's a must. I came to the point of there's 5 factors I believe that can impact men with who are diagnosed with breast cancer, and I believe blood type is at the top. So my blood type is AB. I don't know if any of the doctors or have come across that research, but I encountered some writing that said men with blood type AB are more susceptible to male breast cancer. Um, it was in a book, I believe it's called Eat Right for Your Blood Type. But to further on, other risk factors are age. Uh, age may not matter, but it does. It can. And then tumor size and shape, diet, and heredity. So everyone's touched on those points. And I made the dietary changes. I understand my family history. My father's side of the family is a lot of cancer diagnoses and deaths. And on my mother's side of the family, she had I don't mean to give out her personal business, but she had endometriosis, and so my tumor was ER positive. That's estrogen receptor positive. And so I believe that there was like this perfect combination between those, my mother and father, and creating me that put me at this certain type of risk. Now I've also had, when it comes to employ, I've had numerous jobs, and some of those jobs I believe put me in danger as well. Because I worked around vehicles, worked around cars. I've had gasoline spill onto my chest, and didn't immediately go wash it away. You know, just continued working. If you have a car raised up and you're cutting into, or you're working on the fuel line burst, all that gasoline is going to spill on you. I've worked around paint. I've been covered in paint, and so all these things are. It's just, I believe it was the perfect storm, and it put me into that situation. Early detection saved my life, and Carrie's touch carried me through to this day.
It's very powerful. Thank you so much for sharing with us. We're really grateful.
Oh, you're welcome.
We're
I've got
really
a million
grateful
more
to
things
have
say,
you
but I'm
around.
listening. Thank you. I'm listening.
Yeah.
I'm here.
Please stay around because we're going to open up later on for questions from our audiences around the world. And I'm sure they would have a lot of questions to ask you. So please do stay around if you could.
Yes, I will. Thank you.
Dr. Onyewu, I hear that you may have some slides for us to give a small presentation so that we can help better understand the difference between breast reconstruction and augmentation for men and other very important factors with this disease.
Sure. I had put some slides together because I didn't want us to leave this program without some key information. You can't learn it all in 1 hour. You can't even learn it all in 1 week. But there's some key things I think we need, our listeners and everybody need to take home as far as the incidence of cancer, how to watch out, what you go through once, Hugh Long was talking about what he went through, which is pretty standard. And then maybe I think at the end I might have a couple of pictures just to give an idea of what it looks like to reconstruct a breast or a chest, and so that it's not as dire as people think. People always think, oh, I have cancer, I got to whack off my breast or my chest and I'm going to be deformed. And really in 2020, it's really not the case. I mean, we can really reconstruct and return form and function to people so that you don't feel that loss. I don't know if the slides are up.
Yes, they are. You can go ahead. The slides are up.
Okay. Well, okay. I didn't see them, so I was trying to make sure I went with the slides. All right. So, the first slide, the male breast. I put the slide up because having breasts is actually a lot more common than having breast cancer, and a lot of men have breast tissue. We're all born with a certain amount of breast tissue, and at puberty, when the hormones change, women develop breasts because the balance between estrogen and testosterone changes in the favor of estrogen. But little boys still have estrogen, grown men still have estrogen. So if your balance is not as wide, then you as a young man can actually develop breasts called gynecomastia. It's benign, it's perfectly normal, and we all develop it. Now, sometimes little boys or young men will develop a lot of this breast tissue, and then it starts to bother them. That's called gynecomastia. That's benign. It's not cancerous, and it usually starts around puberty. Puberty used to be 15 back in the day. I think it's like 9 now. I don't know what they're eating, but puberty starts a lot early these days. But it's really an estrogen testosterone balance. All right, next slide. Cancer, on the other hand, is an abnormal growth of tissues. And in the breast really has two distinct types of tissues. You have the milk ducts, which are what carry the breast milk to the nipple, and you have the lobules, which are the breast parenchyma that make the milk. So a certain type of tissue makes the milk, they dump it into the ducts, and the ducts carry that milk to the nipple. So you would think that it's more common to have cancer in the tissue that makes the milk, but it's not. It's more common to have cancer in the ducts, right? When people are talking about types of cancer, infiltrating ductal cancer is the most common. These are cells that are in the ducts of the breast that multiply out of control, basically, is what happens. So, and that's abnormal. So gynecomastia, normal breast tissue, when you have cells that have lost control and are multiplying rapidly, that's cancer. Much more common in the ducts, less common in the lobules. Next slide. 1%, I think what somebody said it, 1% of all breast cancers are in men. And so you may say, 1%, that's not a lot. But if you think of the fact that almost 300,000 new breast cancer cases are discovered every year in America, and I'll say that again, 300,000 new breast cancer cases are in America every year, 280 so thousand. If 1% are men, that's about 3,000 men. That's a lot of men. So while people say it's rare, yeah, it's not every day. It's really not that uncommon. There are 3,000 guys out there, and those are the ones that are detected. Think about all the ones that are not. Hugh Long went a year before he even sought attention. To be honest with you, if he wasn't fighting with his nephew or play boxing, he may never have gone to the doctor, because I can assure you the pain really had nothing to do with the tumor. That was just his God say, hey, get your butt up and go, because the tumor was painless. It was the kick or the hit that caused the pain. So 3,000, I think, is an underestimate of what really we see. And that's why it's important that if you have a lump in your chest is not normal, period. I don't care why you think it's not going to go away, and if you say, get it checked out. It's really that simple. It's not normal, no more normal than a lump on your head or on your wrist or anywhere else on your body. Go get it checked out for men. Next slide. And I think I mentioned this earlier. If the tumor is localized, and I didn't break it into stages because I didn't want the message to be lost in the writing. Stage 1 means the tumor is less than 2 centimeters and it's still in the breast. It hasn't gone anywhere. It didn't go to the lymph nodes. It didn't travel anywhere else in the body. That's a stage 1. The 5-year survival is over 96%. If it has spread, and that's a stage 4, it spread to the bones or the lungs or some other part of the body, the 5-year survival is 22%. That's a huge, that's a factor of 4. That's 400 times, 4 times more common, 4 times more survival if you catch it early. So the question is, if we can catch all these tumors at stage 1, then we literally can, for breast cancer, we can almost eliminate death from breast cancer. It's really that simple. If we can catch them all early, we can wipe out people dying from breast cancer. And how do you catch it early? That's the question. All right. So next slide. Early detection. People have to be aware. Men, women, doesn't matter. You got to be aware of your body. When you feel something that's different, that's not normal, you need to go get it checked out. Dr. Thorpe talked earlier about getting your annual physical. If you're too lazy to check your body every month and you're just ambivalent, go every year. Once a year, go see your doc. Let them examine you and let them feel if there are any. They're always going to feel for that. They're going to ask you questions. Has anything changed in the last year since I last saw you, in the last 6 months, last 3 months? Dr. Thorpe talked about developing a relationship with your primary care provider so that you can have a conversation with him or her. And you can talk about things that have changed, and your diet may have changed. You might have picked up some weight. That's why they're there, to help you navigate. So early detection, picking up these tumors early, seeking medical attention, And then once you seek that medical attention, then the ball starts rolling. That's when you get, they do the fine needle biopsy, or they do the mammogram, and all these other things that we are trained to do. But painless lump, don't wait till it's bleeding or painful. It doesn't matter. Painless is much, much more common a presentation than pain. A mass that's not going away, that's getting bigger. That's another warning sign. Nipple discharge in women, more common in women, but it can happen in men too. A man shouldn't have any nipple discharge. So whether it's bloody or clear, it doesn't matter. That's a trigger. And if your nipple's normal your whole life, and then suddenly one nipple pops in and won't come out, that could be a sign that there's a tumor growing right below the nipple, the areola, that is tethering the nipple tip and bringing it in. The breast tissue in men is most commonly located right under the nipple. And so nipple inversion or retraction is actually a pretty, it was pretty red warning, pretty blatant sign that, hey, I need to get this checked out. Okay, next slide. Most docs will start you off with an ultrasound or mammogram. I put ultrasound first because ultrasound is more useful in the younger people. The breast tends to be more dense, and the mammogram doesn't really see the tissue very well if it's very dense. As you get older, your body replaces breast tissue with fat, and it becomes more translucent, and so the mammogram works better. But if you're under 35, and Hulon was 39, they're going to do an ultrasound. If it's lobular cancer, I talked about the ducts versus the part of the breast that makes the milk. If it's in the lobules, bilaterality is very common, both sides. So even if you feel a lump on one side, they're going to MRI both sides to look at both sides, because it's very common to have a synchronous tumor on the other side that you don't even know about, that you might have been feeling. So these are the things, and that's why doctors may pick different tests depending on what they're thinking. So it's not always going to be a mammogram, and that's the only reason why I put that. There are other modalities to look at the breast. Next slide. Prompt treatment goes with prompt early diagnosis and prompt diagnosis. I talked about lumpectomy with radiation versus mastectomy. Survival is exactly the same. Mastectomy, though, there's a slightly lower chance of recurrence because you remove all the breast tissue. There's no breast tissue left to have a recurrence. With the lumpectomy radiation, there's a low incidence. I think it's about 5% recurrence. However, if it does recur, you can then have a mastectomy, and then your survival is the same. So survival is the same. Recurrence is a little different. Chemotherapy will be used if you're either high risk or if you have tumor that has already left the breast. And then reconstruction is always an option. Two broad categories, and without boring anybody, we can use implants to recreate the breast. We have pectoralis implants to reconstruct the chest for men if we have to take part of the muscle when we take the breast tissue. Fortunately for men, a lot of times we just take out the breast tissue. We even leave the nipple behind. We leave the nipple, and then the chest is actually flatter and more, muscular or whatever. It looks better when you remove the breast tissue. And so we don't have to rebuild anything. Rebuilding is just much more common with women, and that's implants. Or we can use natural autologous tissue, which is what Josephine was talking about earlier. We can take tissue from your belly or from your back, and we can rebuild a breast or a chest wall. I think I have a next slide. All right. So this first slide I show to make 2 points. On the left of the screen, you'll see a smaller breast with no nipple. That lady had a mastectomy on that side, and we reconstructed that it's her right, but our left. We reconstructed that side with an implant. We first put a tissue expander to stretch out the skin, because you lose some skin with a mastectomy, and then we replaced that with an implant. The problem was that the implant, the implant sits up high, doesn't really drop, and her other breast had dropped, which comes naturally with age and time. And so we did a lift on the non-cancerous side to match the reconstructed side, and that's the picture on the right. It's the same lady. We just did a lift on the left breast and raised it up to match the right. And while we were there, we made another nipple for her and tattooed her areola. So she had a pretty decent and felt very good. Felt like she was herself again. You know, your self-esteem. You walk around, you don't feel like something's missing or one part of my chest is flat. Not everybody elects to have a nipple redone, but she did, and she had the tattoo. So she was, you know, very happy, and her cancer treatment wasn't as dire and as dreadful as people had imagined. Next slide, please. This lady, I showed the two pictures to show she had both breasts removed. She had cancer on one side, but genetically, she had what's called the BRCA gene, which patients who have that gene, 100% of them will develop breast cancer at some point in their life. So it made sense to take both breasts off as her treatment. She was young. And then we took tissue from her belly and we made her 2 new breasts. So on the picture on the right, the skin you see in the center, which eventually we tattooed and built a nipple on, is actually skin from her belly. And all the tissue inside is fat and muscle from her belly. And we're able to build breasts on both sides. Subsequently, she had her nipples, I don't think I have the picture here. She had her nipples reconstructed and then her areola color tattooed in. Next slide, please. I think I just showed this as a close-up that sometimes it's difficult to tell that somebody had a mastectomy. The picture on the left shows that scar above the nipple. That's the scar you get from a mastectomy. So she had a mastectomy. She had her nipple removed, her entire breast, some skin. We rebuilt that side with an implant, this lady, and then we made her nipple and tattooed her areola color. And I showed both just to give you an idea of how close. I mean, it's not perfect, but how close you can get to the original breast. Next slide, please. All right, so this is male, and this is typically what you will see if a man comes in and says, you know, I've had breast tissue since I was 18 and it just keeps growing, hasn't really stopped. Sure, the first thing we do is we do an exam, a testicular endocrine exam, make sure that he's not making some hormone abnormally, and 90% of the time that's normal. And then we did an ultrasound to make sure there are no lumps or masses that we need to worry about. That was normal. And then with him, we just took out all this breast tissue, all this abnormal growth of breast tissue in him. And you can see the picture on the right. I didn't even have to put anything back in because now his normal pectoralis muscles became more prominent. We don't even see a scar. We put the scar around the nipple, and so it just healed back into the natural line that you have there, and that was his final result. So my take-home, I think that's my last slide. My take-home message really is that you have to be aware. It starts with awareness. Like Dr. Thorpe said, you have to take it seriously. It's not play stuff, and the reason you have to take it seriously is because it could be a life or death situation, and it doesn't have to be. It really doesn't have to be. I mean, we fight to make sure that we convert all those stage 4 to stage 1 so that we can treat people and they can go about with their life and do their 30th wedding anniversary, walk their daughter down the aisle, do all the things that make a life fulfilling. That's what we're fighting for. And I think if we all band together, this can be done. Thanks.
Thank you so much. That was very powerful. We have a couple of questions that are coming in for you, but what we're going to do is we're going to transition to have Dr. Thorpe. I believe you also have a small presentation.
My presentation has already occurred.
Okay, perfect. And so then I would ask Dr. Emeka, let me go ahead and ask you this question from our audience that's watching online. Does insurance cover reconstruction? If not, are there programs that assist patients with financial burden?
That's a great question. Up until 99, we had to fight insurance. And of course, now I'm giving away my age. I was still practicing medicine then. But we had to fight insurance companies to cover reconstruction because they felt that it wasn't essential, that it wasn't treating any disease. We actually had to publish studies, the plastic surgery world had to publish studies that showed that women who had their breasts reconstructed had a lower incidence of depression, self-worth, et cetera, et cetera. A bunch of things we looked at. And it was only after that study got published that insurance companies started covering reconstruction. So the short answer is insurance companies have to cover reconstruction after cancer. And for people who are uninsured or underinsured, there are lots of programs. Maryland has, all the states have state programs, but Maryland has specifically a cancer treatment program that as long as you're diagnosed with cancer, you qualify. So I know that for sure in Maryland, but almost every state has something that along those lines.
Thank you so much. Thank you. And as the questions come in, I'll be asking you. So I remind our viewers, please, you can put in your questions either on our live YouTube streaming or on Facebook Live, and we will ask the doctors. And we also, don't forget, we have Hulan on as well, and we would also have them answer your questions. So Dr. Thorpe, you spoke earlier on our family history and how important that is. What does all of that mean for people of color who do not fit national guidelines or participate in clinical trials? How do you flip the script?
Yeah, so that's a good question. It's very relevant as we talk about these clinical trials that for the COVID-19. It's very, very relevant in today's space. I think it's very important, first, for the family history. You know, we have to get over this hump and start being able to talk to one another, because, you know, family history of cancer is a strong, you know, that's one of also the risk factors. And so I think if you know you have a family history of it, then or someone, if the person who has it, the condition, you could do like what I think Reverend Denise talked about. You can start having these supports within the family. We just got to get over not wanting to share our conditions with one another, you know. And there's a couple things that run in Black families: hypertension, diabetes, obesity, and certain cancers. Right? They run in these families. We need to be able to articulate to one another who has it. And so when you go to the doctor, you can provide the doctor the relevant information in your medical file, right? So if you are in a position where you can't communicate for yourself, at least that information has been articulated and is in your medical record. And as it relates to these clinical trials, listen, it's just this simple. It's just this simple. If we're not in the trials, then the results that come out of the trials may not work for us. Right? It is just that simple. So we have to participate in these trials in order for the results in order for us to feel confident that the results that they have can work for us. But I think it's not just a small number of us. We have to have a sufficient number of us. So what we're running into nowadays is we have smaller numbers of particularly Black men in a lot of trials. And yeah, we got a few of them, but I don't think the numbers are large enough for us to make meaningful decisions about how to treat things and how to create policies and those types of things moving forward. So I would encourage people, to the extent that they're comfortable, gain knowledge, like Reverend Denise said, understand it, gain knowledge about it, before you get into it. And then if you feel comfortable doing it, then I encourage you to be in these trials. Otherwise, if we're not in the trials, we're not going to know when they say the trial is effective and we don't have Black people in it. We don't know if it's effective for us. It's effective only for the people we know definitively is effective for only the people for whom participated.
That is so true. Does anyone, Reverend Tammy, Dr. Emeka, would you like to add to this as well?
Yes, I would. In particular, I am 100% on board with what Dr. Thorpe is saying. And the piece that I would probably add to it from the community voice is that, first and foremost, you know, we're scared. Unfortunately, Tuskegee still plays a huge role in our communities. And so we have to first address that. And one of the ways that I do it, I ask the person, you know, tell me about the Tuskegee trial. Most of them don't even know what it really is. They just know that Black people were mistreated. And so I said, okay, yes, that was true, but there are literally, you know, tens, if not hundreds of thousands of amazing physicians and researchers out there available, and you can't complain. So I try, my approach is to empower them again to go get the information that you need. And then talk about my experience. I entered a clinical trial. My oncologist asked me to participate in the clinical trial. And I asked him, well, how are Black women responding to this trial? And he said, I don't know. And I said, that's unacceptable. You cannot walk into this exam room and present a treatment option to me, and you don't know how women that look like me are responding to it. And that's when I became very, very engaged in clinical trials and research and trying to advocate and educate the community to participate in clinical trials, exactly like Dr. Thorpe said. But I tell them, listen, don't complain about what's happening with you with this medicine if when the opportunity presents itself, you don't choose to participate in a clinical trial. You know, and a clinical trial is not for everybody, and they say, I don't want to be a guinea pig. Ask questions. When I told my doctor that wasn't acceptable, I asked to speak to the researcher. She handed me 32 pages of possible side effects. And we sat down for 4 hours and went over all 32 pages. Patients don't think that they can ask for that. I'm saying, this is my life and I want to live. And if I don't fight for my life, then how can I expect it all to be on the doctor? So I charge the community to take ownership for their part in their own healthcare. So I piggyback everything that Dr. Thorpe has said as well.
Josephine, may I respond to that,
Yes,
please?
please.
Reverend Denise, that was outstanding. But I do want to make the caveat, and I think Dr. Unway, I hope I pronounced your name right. It's rare to have a physician sit down with you for 4 hours to go over all the side effects. So, but that made my day though to hear that. That was really beautiful.
Well, it wasn't the physician, it was the
Okay.
researcher. It was the
Oh, okay. I'm
researcher.
sorry.
Yeah.
Okay.
She wasn't ready for it, trust me. She was not. She's like,
Right.
well, these are just the least ones. I was like, yeah, but the last one on the last page says death. And if I'm trying to live, I need to know what's going on in these first 31 pages. So, I'm a little different. I treat, but I teach folks my methods and, yeah, but it wasn't the doctor.
Okay.
Yeah.
I think the take home message is the trust and the relationship. You could ask your doctor that because you felt comfortable.
Mm-hmm.
I think if you see your doctor once every 10 years, or if your doctor is the emergency room doctor you're meeting for the first time, it's going to be a lot more difficult to have that kind of conversation. But when you have a relationship with a physician and you see them every year and they know you, they know your dog, they know your kids as they grow,
Mm-hmm.
I think it's easier to have that kind of rapport. And I think you'll be more comfortable asking those kind of questions. But I 100% agree. You gotta ask. You gotta ask these things, and you gotta hold your doctors accountable too.
That is so great. I think Hulan also would like to say something to this effect. Hulan, please go ahead.
Can I just
Oh,
very,
sorry,
very
go ahead. Mm-hmm.
Dr. Mecca, I don't want to mess up your name, but this was my oncologist. This was the second time I had met him. And I just knew that I wanted to live. I didn't know him. I didn't have a rapport with him. And in that moment, I didn't even like him. I didn't trust him. None of that. He was my oncologist. So this was my second meeting with him. Yeah. But, I think you're right that people can be more empowered when they do have those relationships. But that wasn't the case. I just knew that I wanted to live.
Thank you so much. Hulan, please go ahead with your question.
Oh yeah, I just wanted to say that everyone touched on what I kind of wanted to touch on, but I did start to panic when I looked on the paperwork and I came across the term deleterious mutation. When I saw that, that's when the panic attack started for me. Deleterious mutation, and just to get technical for a second, I wanted to let you guys know that it was it was stage 2. I was at stage 2, and the tumor was grade 3. if that helps anyone.
Yeah, so understanding the terms and the words and what it meant and what it implicated would have been really helpful for you so you don't panic. And so I think what Reverend Tammy is saying, having someone really take the time to sit with you through the process to understand what these terms are and what they indicate and what they actually mean would be very helpful so the patient doesn't panic and it causes more anxiety and confusion.
Yes, and that's what the support group meetings were a big help for, understanding everyone's situation, all of us together. It was extremely helpful.
So the importance of community. I think one of the things we wanted to talk about is community. How do you sensitize the community, number one, to destigmatize, to encourage, to provide support, and having these support groups inside, probably where they have clinical trials, the hospital, but also outside where community can come in. How do we do that? How do we work on that, Reverend Tammy?
People typically go to churches when you want to engage the Black community. And that's a great place to start, but I say that that's not the only place that you go. Go into hair salons, go into barber shops. I go into hair salons and I just sit. And then we start a conversation about breast health. And then, you find out someone's either had it, their grandma's had it, someone that they know has had it. Then we get to talk about the importance of early detection. One of the things that I help patients with as they go into their doctor's appointment is not only prioritizing their questions, but have a team that goes in there, but it's a team with purpose. You have a scribe that comes in and they're just writing down and they ask the doctor when they say these long medical terms, will you please spell that so that I can look that up later? Or do you have any literature on that, that whatever that term is? It could be medicine, it could be diagnosis, to help me better understand what this is. Then they actually, everybody has a cell phone these days. Ask the doctor, may I please record this session so that when I go home and debrief what you said, I make sure I understand the treatment options that you're presenting to me. That's if you're in early stages. So you have a team of people that go in with you, but they're not to antagonize or interrogate the doctor. They're as a support system to help you understand what the doctor said, because as the patient, you blank out. As empowered as I was as a patient, there was always a point that I just dropped out of it because you're going, is this really happening to me right now? And then you don't hear anything the doctor says. And then the doctor asks you, what do you want to do? I teach patients to ask the doctor, how much time do I have before I have to give you a decision? And, unless it's extreme cases, most doctors will give you at least 24 hours to go home, talk to your family about it, debrief about, what the doctor said, look up the terms, and internalize what's going to be best for you. So bringing in community is critical to how you engage with your doctor. And when I go in, I get to say, I start off the bat. I am here today by the grace of God to be a 16-year breast cancer survivor. And I say Black women and men can and do survive this disease. Yes, we have disproportionately high mortality rates, but there are still a large number of us surviving this disease. And the more you see us, the more opportunities others can come in and say, hey, I can survive this disease as well.
Thank you so much. We're going to take one. We're about to close our session. We're so grateful for all of you. We know how busy you are, and taking this time off is very, it means a lot to us, but we don't want to take too much of your time, as we know you're busy saving lives and reconstructing lives all over again. So we have a question from Betty on Facebook, and she's saying, if a female member of your family
Do you want to promote your business? Do you want to talk about your nonprofit organization? Do you want to talk about your culture? Introducing the online web TV, Afric Today. Fogham, where you can watch us live at the same time on 4 platforms: Facebook, YouTube, Twitter, and using the Afric Today app. Download our app today for Android or Apple. Promote your business today. For more information, go to www.africtoday.com. Afric Today, the best of digital TV.
L'entrepreneuriat digital vous intéresse-t-il? Vous voulez apprendre à construire des projets digitaux? Aimeriez-vous gagner des revenus passifs conséquents en tout lieu? Voici la plateforme des professionnels du digital, la Diaspo Academy. Ici, vous retrouverez les meilleurs professionnels de la diasporama mondiale connectés sur notre plateforme. Vous allez pouvoir acquérir des formations adéquates qui feront de vous des entrepreneurs digitaux compétents. Étudiants, entrepreneurs, coachs, instructeurs et entreprises, Diaspo Academy est une opportunité pour vous. Elle vous offre la possibilité de suivre votre formation en mode virtuel à partir de chez vous, ou que vous soyez sur la planète. Toutes nos formations disponibles en ligne sont dispensées de manière interactive. Il suffit de vous inscrire et vous pourrez les suivre depuis chez vous. Au cours de la formation, vous passerez des quiz et examens selon votre parcours. En outre, à partir de votre tableau de bord, vous suivrez vos performances et progressions. Vous pourrez aussi communiquer avec vos instructeurs et recevoir des notifications. À la fin de votre parcours de formation, vous recevrez un certificat Diaspo Academy Certified. Que vous soyez débutant ou responsable d'entreprise, Diaspo Academy est une opportunité pour vous. Saisissez-la. Enfin, que vous soyez coach ou instructeur, ayez accès à un millier d'étudiants à travers notre plateforme. Merci de choisir Diaspo Academy, le meilleur choix. Pour plus d'informations, allez sur www.diaspoacademy.com. Diaspo Academy, la plateforme des professionnels du digital.
Thank you. So I guess we had some technical problems there. Dr. Emeka, please, let's go back to our question from Betty, who was asking if somebody had a family member that was female who was diagnosed with breast cancer, would other family members, meaning probably male family members, be concerned and go in for screening as well?
All right, so there's a short answer and a long answer. The short answer is...
I don't know if Dr. Emeka's sound is working. Can you
hear me?
Can you hear Dr. Emeka? Okay, go ahead, Dr. Emeka.
Yeah, there's a short answer and a long answer. The short answer is yes. First degree relatives are a known risk factor for breast cancer. So if you came in to my office and I was worried about breast cancer in you, I would ask you whether your mother or an aunt or first degree relative that's had breast cancer, because that puts you in a different category. So the answer is yes. If a family member who is a first degree relative has breast cancer, it puts all the other first degree relatives at risk for having cancer at an earlier age. And they should get screened a little bit earlier. It used to be you got your first mammogram at age 40, but for the high risk people, I think they get it at 35 now. So it's a little bit earlier. The long answer is this. If that family member has breast cancer, you want to get a genetic profile. And I know it's a little bit complicated, but that's if you just remember genetic profile, that's all you have to remember. They will take that tumor, they will run the genetics on it, and they will tell you whether you have the BRCA gene or not. And if you do, who's at risk. They'll just give you a whole breakdown of who's at risk and who's not at risk, or if it's just a random mutation that caused the breast cancer. So the short answer is yes, everybody should be screened and screened a little bit earlier. But the person with the cancer should get a genetic screening.
That is so helpful. Thank you so much. I think we are coming to an end of our program, and I'd just like to give everyone just a minute. If there's anything you would like to say to our guests, don't forget you are being streamed all over the world. So raising awareness, not only nationally, but internationally, what should people know? And so I'll go across and then we'll go to Hulan as well. So Dr. Thorpe, why don't you start and give us a minute, just something you'd like to say, a message, a final message for our guests who are listening across the world.
Here's my final message is simply this. Share your family history and engage in the modifiable things that you can do, and modify your diet, adhere to treatment regimens, establish a annual visit for the men who don't have annual visits, and and if you don't have a doctor, build a relationship with the doctor. Even if you do, you should build a relationship with your doctor, because like Dr. Anwu said, if we band together and stick together, we can beat this thing.
Thank you so much. Reverend Tammy?
I think the main thing that I want to communicate to those listening is early detection saves lives. Though I had a very aggressive cancer, I was diagnosed at a young age. I went in and I wanted to live. And so if you want to live, go in with your doctor and speak life and know that Black women and men can and do survive this disease. So come join us in survivorship if you're diagnosed, and reach out and ask questions about what resources are available to help you navigate this disease.
Thank you so much. So we have a question that came in. I know I'm giving you all a final say, but this was so important. And it says, do mammogram guidelines apply to men? And Dr. Emeka, since you're going next, I think that would be a very important question that our audience would like to know.
No, mammogram guidelines don't, because we typically don't have the same volume of breast tissue that women have. We just don't. We generally have a small amount, and mammograms wouldn't help us. However, if you have a first-degree relative who has cancer or who has the BRCA gene, I think the men should be screened also, and that would probably be an ultrasound, not a mammogram. But for my 1 minute stand on the podium and preach, I would say this. Black and those of African descent tend to get cancer at an earlier age and tend to have a more aggressive cancer, as the Reverend is fully aware of. It puts the onus on us even more to be more alert and aware, to do the monthly exams, to look for the lumps, to seek medical attention earlier, because we are at a higher risk. And cancer in Blacks may even be a completely different animal than cancer in whites, because the studies, like Dr. Thorpe said, we didn't participate in those studies, so they're not even sure if what they learned applies to us 100%. So it's more important for us to detect this early and treat it early. The second thing I'll say is we have to start to get rid of some of these myths that stop us from getting help. We need to we need to teach our younger ones early that no, you can't hope that something's going to go away. It's not a curse from your enemy. It's not, prayer. Yeah, you got to pray and hold your faith, but do both. Pray and go seek medical attention. Don't do one. It's not conspiracy. We need to get rid of some of these barriers that culturally we have as Blacks and African Americans that stop us from getting early health, to seeking health attention early. And if we catch it early, it really is a 100% curable disease.
Powerful. Thank you so much. Roland Thompson.
Oh, yes. Thank you, and thank you, everyone. Lastly, I wanted to say, if you are diagnosed with any type of cancer, but we're talking about male breast cancer today, if you are diagnosed, you've got to go out there and you've got to find your people. You have to seek out your people, or better yet, they'll find you, but you have to put yourself out there and let people know, because it's not an experience that you want to deal with alone. And some people have it easy. Some people might have a 2-car garage, nice home, a primary doctor, and everything's going correctly for them. And some people may not. And for the ones that don't have that family support, or the primary doctor and everything that you feel like you would need to fight this battle, just know that those things are out there, and they will come to you. You have to step out that front door and find those individuals that will help guide you through the situation of dealing with male breast cancer.
Reverend Tammy, Dr. Emeka, Dr. Thorpe, and Mr. Thompson, thank you so much for what you've done today, and thank you for everything that you continue to do every single day, saving lives and making differences in so many lives. On behalf of the Michael and Mauritia Patcher Foundation, the Assembly of Petworth, Immigrant Community Services, we thank you for being here today and giving of your time and talent to us all. These are life-saving discussions, and we will take this and we will keep playing it and keep sharing it with others. And we hope our community would understand the importance of clinical trials and, most importantly, of early detection. Many thanks and very special gratitude to a special person in our community, Mr. Ray Bridgewater, who is really behind the scenes in making this possible and reaching out and working, sleepless nights to reach out to our panelists and to put together the program. Would also like to thank Alan of Afrique Today. Without Afrique Today, we would not be able to live stream these conversations in such high quality resolution and across the world. So Afrique Today live streams on Twitter, on Instagram, on YouTube, and Facebook Live, and all over the world. We have thousands of audiences that tune in and watch this over, every day. So we're very grateful for that. And thank you to our audience. Please take this information. If it's not for you, at least share it with your community members. Cancer is very, very serious in our communities, especially in the Black community. And of course, nobody really thinks about male breast cancer, but as we know, it is there and it is real and it is dangerous. So please share this information with others. I thank you so much. I wish you all a great weekend. Please stay well and stay safe.
Do you want to promote your business? Do you want to talk about your nonprofit organization? Do you want to talk about your culture? Introducing the online web TV, Afrique Today. Fogham, where you can